Okay, Agnes, Tanya's all set up, so we can get started whenever you're ready, okay?
Good morning, everybody. Thank you for coming to the CIVIC talk on opioid crisis and the stigma of addiction. Today's presenter is Dr. Jonathan Avery. Dr. Avery is currently the Director of Addiction Psychiatry and an Associate Professor of Clinical Psychiatry at Weill Cornell Medical College and New York-Presbyterian Hospital. In addition to his clinical work, Dr. Avery teaches addiction psychiatry to the Weill Cornell medical students and residents of New York-Presbyterian Hospital. He has been published on a broad variety of topics in psychiatry, including papers on subjects ranging from clinical attitudes towards patients to how to use buprenorphine. He is the founder of the Weill Cornell New York Presbyterian Program for Substance Use and Stigma of Addiction. He was on the editorial board for the DSM-5 clinical cases book and is the editor of the books Co-Occurring Mental Illness and Substance Use Disorders, a guide to diagnose and treatment the stigma of addiction, an essential guide. He has won numerous awards for his clinical and academic work, including the American Board of Psychiatry and Neurology Faculty Innovation in Education Award and the Outstanding Faculty Member Award from the New York County Psychiatric Society. So it's a pleasure to have Dr. Avery present for us today, and we're excited to see what you will be showing us. The next voice you'll hear is Dr. Avery. Thank you.
Thank you, Agnes, Jeff, and everyone for the kind introduction and for thinking with me about the stigma of addiction and the opiate epidemic. And I'm joined today by Robin Kellner as well. And so the agenda for today is I'm going to discuss a bit of a background on the opiate epidemic and the stigma of addiction. I'm going to turn it over to Robin for a bit to tell her story and Zoe's story about why this is also important. And then I will talk about some of the treatment options that we consider in this landscape. And so I'll share my slides. Can everyone see my slides okay? All right. So the stigma of addiction and the opiate epidemic, I'm John Avery again. I don't have any financial relationships, so a lot of my work is taken from my books on the stigma of addiction and addressing co-occurring mental health issues and substance use disorders, as Agnes was mentioning. And as I said, we'll talk a little bit about the opiate epidemic, where we're at, what the latest news is, talk about the stigma of addiction, which I think is one of the big reasons the opiate epidemic continues. And then we'll pause and hear Robin's story and Zoe's story, and then we'll talk about some treatment options. And so, you know, I'm not an anti-opioid guy, and you know, we just have a long history of not being nuanced about our understanding of opiates. And you know, historically, we've thought all opiates were bad or all opiates were good. And there's a complex history that's worth exploring. If you haven't read Dreamland by Sam Quinones or Dope Sick, you know, there's a lot of interesting articles and books to think about how we got here as a society. You know, jumping ahead though to the sort of more recent history is that in the late 80s, early 90s, pain was the fifth vital sign. We thought as a medical community that you couldn't go wrong prescribing people opiates for pain. And my dad is a hospice physician, and he remembers in the early 90s, the drug company would come to his office and give free opiates to people just in case they were ever in pain in the future. You know, opiates were sort of everywhere. They got overprescribed. I broke my foot, you know, like 20 years ago. I got 180 Percocet and I only used one. I mean, everyone was just getting a ton of opiates for everything. And then, you know, what happened is that the opiates flooded the market, people started misusing them, and you know, we entered the first wave of the opiate epidemic, which was the rise in the prescription opiate overdoses, resulting in a lot of deaths. We got wise to this as doctors and clinicians, as a society, and we started cutting down on the overprescribing of opiates. But then we had so many people who were stuck using opiates, and we didn't have good treatments and accessible treatments. You know, the treatment landscape for addiction has always been so poor and under-resourced. And so people turned to heroin, which was sort of the phase two, the wave two of the opiate epidemic. And, you know, we've increased access to buprenorphine and some of the treatments I'll mention in a second. But, you know, every time we counter a wave, something else happens, and wave 3 has been the scariest in my opinion, in that, drug companies, people that sell drugs, got wise to the real need to people wanted opiates and they weren't able to get it, and so synthetic opiates, especially fentanyl and fentanyl derivatives, were shipped in from China and Russia, pressed into heroin and other opiates, but also suddenly pressed into a lot of other drugs like cocaine, pills marked as Xanax, Adderall. And so this third wave of the epidemic is the scariest because about half the people overdosing from opiates know they're taking opiates, and about half the people overdosing from opiates don't even realize that they're getting an opiate. That is, fentanyl is contaminating pretty much anything that doesn't come from the pharmacy. Add COVID-19, all the stresses of the last 2 years, and we've seen a record amount of overdose deaths. Some numbers saying top billing 90, 100,000, in addition to all those folks that have near overdoses and have the medical consequences from that. And so we're still in this incredible crisis that is the opiate epidemic. And here sort of highlights what the New York City Department of Health has done in response to this. They have these signs everywhere, that even if you think you're avoiding opiate, and certainly there's the risk of heroin being contaminated by fentanyl or prescription opiates being contaminated by them, but we're also seeing it in cocaine and Xanax, and the stakes are high these days, and many people are losing their lives, about 10 a day here in New York City. I mentioned earlier that it's at record numbers in 2020, and then the New York data, this is a couple years old now, but is it's increasing even further in that it's out surpassing murders and all the other things you hear about in the news. We sometimes forget about the opiate epidemic still claiming more lives than anything else in New York City. It's across borough, cross demographic, old to young, no one's immune. And the one striking thing is that adolescent women, I just saw a report that they had a huge uptick in opiate overdoses. And so, it's really impacting everybody. Just as impactful as the opiate epidemic is our attitudes towards these folks who are struggling with substance use disorders or are using opiates. And I think one reason we haven't been able to get our hands around the opiate epidemic is the stigma of addiction. And when I talk about addiction stigma, I'm referring to the negative attitudes towards individuals with substance use disorders that rise on one account of the substance use, but also are likely to impact physical, psychological, social, or professional well-being. That is, as much as we say we want to help individuals struggling with opioid use disorder, there is still this idea that these folks are bad people doing bad things. And I think the core of addiction stigma, why we distance ourselves from this problem as communities, as societies, as individuals, is that we reject the disease model of addiction. We know half the risk for getting in trouble with opioid use disorder is genetic. We know once you start using it, it rewires the reward pathway and all these neurocircuits in the brain that make change very hard. Yet we still at times as a society view it as problematic behavior and not as the real brain disease that it is. And the impact of that is that it impacts our language. We call people clean or dirty or addicts, and we sort of define people in ways that you lose sight of the whole person. And one of my favorite quotes in addiction is that we're not we're not bad people becoming good as we get into recovery, but really sick people wanting and learning how to get well. And because we've rejected this disease model of addiction, we've situated ourselves as a society in a way where we punish folks, as I mentioned. And this is another great book to read about the opiate epidemic, The Big Fix. And Tracy writes eloquently, Americans love drugs, but hate the people who use them, especially if they are poor and are not white. We send these people to prison. And, the stigma is seen in so many levels in the media. We blame individuals. We don't talk about all the societal factors and the racial factors that go into all the factors that cause an individual to use. We either glorify substance use or we view it as sort of the bad folks in any story, and we haven't had a nuanced portrayal of it in the media. Certainly substance use gets tied in with racial stigma. You can see some of the studies here that have showed that, participants assign greater blame to Black individuals who develop drug dependence compared to white individuals. And the consequence of these racial attitudes combined with substance use is that it impacts our physicians, it impacts the legal system, and we have a whole system that, as I mentioned before, and I'll mention again, is set up to just punish folks. I mean, it's our whole legal system, the jails, the prisons are filled with people with low-level drug offenses. All our money's spent to imprisoning them and less toward providing substance use care. And of course, we feel we can't talk about it at work. We can't talk about it in our families. And then the sum of all of this stigma, including the stigma that exists in the healthcare field, is that it situates people, it results in self-stigma. It's basically it situates the individual with substance use disorders in a place where recovery is made even less likely and more remote, decreases willingness to involve others and seek treatment. It impacts work, family, friends, and relationships. If you're being told by everyone that you're a bad person doing a bad thing, that you should be punished or go to jail, you start to think that about yourself and punish yourself, and you start to not want help, and that's the sum of all this stigma that exists. And so, and as I mentioned before, my primary research interest is on the stigma that exists in the medical community and also in the legal community. And even doctors, I've shown, have worse attitudes towards substance use disorders than towards any other medical or psychiatric condition. And so even in the places that should be the safest, like your doctor's office, that shame and stigma still exists. And to sort of highlight these issues and to highlight why it's so important, I joined by my good friend and colleague who does all these talks with me, Robin, and she'll tell a little bit about her story and Zoe's story and about why it's so important to pay attention to stigma and the opiate epidemic. And then I'll come back and resume my slides with talking about some of the treatments that do exist. So Robin, thanks for joining us. I think you're still on Zoom, Robin, sorry.
Gotcha. Sorry, but thank you for having me, and thank you for your interest in this health issue. I always like to, I'll backtrack a little bit. I never thought I'd be the parent that stands before people with a photograph of my daughter, but here I am, and this is Zoe. I hope you can see her. She is a beautiful girl. And on a Sunday night, on April 9th in 2007, Zoe took an accidental drug overdose, and her life at just 22 years old was over, just like that. I know now that overdose deaths are preventable, which makes this so much more impossible. Imagine losing someone that you love more than life, knowing that this didn't have to happen, and that there was and is so much that could have been done. All these years later, it's still hard to believe what happened and how it all unfolded. But first, let me tell you just quickly about Zoe. She loved life. She was interested in everything. She could spend the whole day in Barnes & Noble reading about neuroscience, religion, fashion, and then she'd go back to the brain. Zoe was brilliant and beautiful, and she cared deeply about others. She would have made a difference in today's world, where humanity and empathy are in short supply. But she lived with emotional pain. Childhood trauma was buried deep under her skin. Mostly, she managed to deal with it, putting her best self forward, trying her best. She was in therapy on and off for many years, but that kind of pain doesn't resolve easily. It's hard for a child to reach deep and to look at the pain they're so fearful of. I think it's also hard for parents to deal with many mental health issues, including substance use disorder, which is often not recognized as a real health issue, but rather one that's viewed with shame and stigma and a lack of moral fortitude. A general feeling of, you did this to yourself. You're not the victim here. But let me get back to that later. I think what changed Zoe's life course were a few but significant missed opportunities when we interacted with the medical community. Opportunities to provide us with information compassionately and with clear treatment recommendations. Those missed moments cost us. There was so much negative judgment surrounding Zoe's struggles and my parenting, it almost felt like her doctors had disdain, believing she somehow wasn't trying hard enough. She wasn't really sick. I can give you a good example. In high school, Zoe developed an eating disorder in her junior year. Her pediatrician identified it, recommended she be admitted inpatient at a hospital. And I agreed. Zoe was terrified of having never been in a hospital except when she was born. Unfortunately, when we arrived that day, her doctor had not made the arrangements and there was no bed for Zoe. The nurse said she could sleep in the corridor until a bed was available. That really didn't feel right. So I called her doctor to let her know. Her doctor, Zoe's doctor, her pediatrician said, "You know what I think? What I think Zoe really needs is a good swift kick in the pants. Leave her there for now." I didn't understand it then, but I do now. It was stigma. It was punitive. How does a medical professional not realize that Zoe was ill, not manipulating us? She was behaving in a self-destructive way because she was suffering and lacked the tools to do better. That was the first breakdown in the medical care Zoe would receive over the next 5 years, and then her life would end. I just want to add that later on my own, I learned that eating disorders can be a predictor of substance misuse later. I learned that there's a correlation between eating disorders and substance misuse. That was important information we didn't have. When Zoe went off to college, she loved it. I learned, not happily, that she and her friends experimented with new freedoms, feeling like adults, though emotionally not nearly there. Along with those new freedoms, Zoe experimented with alcohol and drugs. I first became concerned, this was her second year at college, after a few phone conversations where she just did not sound like herself. I flew down to visit, a mother's instinct. All at first seemed perfectly fine, and I thought, okay, I'd rather be a little paranoid than miss something. Sunday, we planned to have lunch before I flew home, but she didn't show up. I thought she must have overslept, been with her friends after we had dinner. Then I got a call from a hospital. Zoe had overdosed, found unconscious on her college campus. She was taken to the emergency room and stabilized. By the time I got there, they had charcoaled her, though she was still really incoherent. The doctors decided she needed to be observed for 36 hours. She was deemed at risk of hurting herself. So we stayed in the emergency room. In that cubicle, she on the gurney, I had a plastic chair for the next day and a half. That's a lot of time. Time to evaluate Zoe. Time to provide information to both of us. Time to listen and understand this youngster. Understand what she did, yes, but why she did it. Time to care and provide what might have been life-saving information. There was enough time to provide referrals, recommendations, time to inform both of us just how serious an overdose is and the risk of future fatal overdose. I learned years later that a non-fatal drug overdose can be a predictor of a fatal drug overdose. That was such important information for us to know. This was the time to provide Narcan, just in case, but also it's such a strong message. But that's not what happened. What did happen was unexpected. Stigma interfered with good medical treatment. She was judged, spoiled, reckless, indulged kid, taking time and space away from someone who's truly sick. Zoe almost died that day. How much sicker does one need to be to receive health care that's also compassionate and humane? That was the second brush with stigma, but I still didn't understand it then. I felt We deserved the treatment that we got, feeling so ashamed and embarrassed because I knew so little about drug misuse and mental health issues back then. And that began this chaotic and alarming period in our lives. Long story shorter, ultimately, I took Zoe out of school and she came back to New York with me. I was able to access some of the most well-respected professionals, and I recognized that I was very lucky to be able to do that. However, little did I know that stigma exists within this highly specialized medical community. Here I am, a mother, frightened and frantic, desperate to help my child, at the same time feeling so ashamed. I had very little information about this health issue at the time. Keeping all that in mind, imagine getting advice like this. A doctor recommended I have Zoe arrested. Another suggested kidnap her to another state where she can be held against her will. Everything was punitive. I thought to myself, is this medical treatment? Are you kidding? Oh, right. There was also a lot of let her hit rock bottom. That's like saying, let's wait to treat a cancer patient until she's stage 4. Well, today I know that rock bottom is like playing Russian roulette with someone's life. She might survive, then again, she might not. And what would she need to go through to finally get to a point where she accepted the idea of being treated? Would she be homeless? Would have her drug use progressed to a life and death stage, more complex, more dangerous, and more embedded? Well, I rejected those recommendations. And eventually I got Zoe into treatment with a psychiatrist who specialized in addiction. And slowly over time, she seemed to come back to herself. But as can happen with this health issue, it ebbs and flows. And when it flowed back, it was terrifying. I started searching again for help. You know, it shouldn't have to be this way. We should be able to talk to our primary care physicians, our pediatricians, and find the support and direction as we would with any other health issue. Every day while I searched for help, we lost time. I didn't know it, but we kept losing time. Then someone at McLean Hospital provided a referral, a doctor who saw me without Zoe, because at that point she refused to come in. She felt she was fine, she was happy, she didn't need help. This doctor explained to me that there was a way to lovingly encourage her to get into treatment so that she could get better, healthier, and move on with her life. We discussed Zoe at length, of course, the drugs, but also what was most important to her. I thought it had to be the drugs, or maybe her friends. My husband pointed out to me, I was most important. Zoe loved me and our relationship, meant the most to her. From there, we created a script. We narrowed our interactions down to one focus. I announced to Zoe in an email, in a letter, and then verbally that the only thing I would talk to her about was going into treatment. She started to miss our interactions. She started to miss me and miss us. And one day when it seemed so unlikely that anything would change, Zoe said, just tell me what you want, but please stop. I miss you. And I want to talk to you. I want our relationship back. Please, I miss you so much. When that happened, she did agree to a more intensive treatment and consented to include me so that I could participate. But we didn't know that our time was running out. We wasted so much of it searching for help, rejecting bad advice, feeling shamed and embarrassed. With so many missteps, we lost so much time. With this health issue, anything can happen at any time, and it did. But it didn't have to be this way. Overdose deaths are preventable. That's just one of the reasons this is so tragic. This didn't have to happen. You know how there are things in life that are imprinted on your brain forever? Well, On a Sunday in April, Zoe came home in the evening and I was preparing dinner. I'm sorry. And I asked her if she wanted anything to eat. And she said to me, Mom, I think I'm going to make myself a cup of tea and go to bed. That's what she did. I didn't know that those were the last words I'd ever hear my daughter say. I didn't hug her that night. I don't think I did. I probably didn't. I'd narrowed everything down and I was keeping to that script. And I assumed I had tomorrow and the next day. After all, we had an appointment set up for that Thursday of that same week. Zoe went into her room that night with her tea. She also took a combination of drugs that caused her respiration to slow and stop. She wanted to go to sleep, but not forever. We were told she died a few hours after she went into her room that night. She made a mistake, and it cost her her life. I'm sorry. I have so much respect for the medical community, especially Dr. Avery and all the terrific doctors at Weill Cornell. But there were and still are some doctors who can look at someone, maybe like Zoe or not, and think she could do better. She needs to try harder, and she needs to be better than this. They assume she is better than this. And that's all true, but not without the right treatment. And not if they keep blaming the patient. I think this health issue is often misunderstood and terribly stigmatized. One day, Zoe and I were arguing about her going into treatment. She said, and it was another one of those I'll never forget moments, do you really think I want to be like this? If I could do better, I would. Can you imagine my daughter needing to tell me what I should have realized? She was so right. No one wants to be that non-compliant person. No one wants their life to be so out of control. But at that time, Zoe didn't have the medicine, the tools, the support to do better. And that's on me. I didn't know enough, but I could have. I could have known more if I'd been informed. It's on our community. When we look at someone struggling and think, that could never be me. That could never be my child. Can I tell you something? Because now I know any one of us can be that person, because anyone can get sick. And when we shame and embarrass rather than offer compassion and understanding, children and our loved ones die. And it's on our doctors to treat this health issue as they would any other health issue, with cutting-edge medications, therapy, support, and yes, compassion. Humanity, kindness, and intelligence is what makes great doctors. At least that's what we look for in ours. Thank you.
Thank you, Robin, for sharing your story and Zoe's story. It always certainly reminds me to be a better clinician, and our hope today is that it reminds us all to be the right sort of community members that realize that this can impact any of us, and something that we all need to tackle together. You know, certainly in the medical community, among our families, in our wherever we are as folks, because this epidemic touches all of us and is increasingly, you know, touching all of us, as I mentioned in the beginning. And so, you know, what can we do? I think, you know, the first thing is to do what we're doing here, which is to, you know, to talk about this and to, you know, to hear stories and listen to those like Robin and Zoe's story about how important it is that we all pay attention to this health issue, that we don't stigmatize it and punish it, and that we're all ready to help whoever needs our help at any given moment. And so I'll talk a little bit about some practical things we can do in terms of prevention, and then I'll highlight some of the treatment options that we can bring to the table when we see someone struggling, and to know that there's hope and that, you know, people can get better. We just need the sort of right care and attention, for sure. to start off in terms of prevention, you should know that there are certain folks who are especially at risk for developing opiate issues if they get prescribed them, or if they encounter substances on the street. And those are those with a personal or family history of substance use disorder, heavy nicotine use, certainly co-occurring mental health issues. We often say that we tolerate what substances do to us because what they do for us. And just as there is the opiate epidemic, the youth vaping epidemic, all these epidemics in addiction, it really exists alongside a mental health epidemic, a trauma epidemic. And people are often trying to get out of difficult, painful states by using substances and not having the resources to do so. And so certainly one way to prevent these mental health issues is also to have more accessible mental health treatments in addition to substance use care. And then certainly younger folks and those with a legal history are more at risk to getting into trouble. And as I mentioned, in terms of addressing co-occurring disorders, I think we have to address them, as I said, with addressing the depression, the anxiety, addressing both physical and psychological pain. And there are a number of good treatments to do this, including therapies, cognitive behavioral therapy, different talk therapies, and then certainly medications, the antidepressants and others that can really help with mood, anxiety, PTSD symptoms. And then one thing to remember is to be careful about opiates when you're prescribed them in terms of prevention. We know that more than 70% of people who get in trouble with opioid use disorder start with opiates they receive from family and friends. People often put opiates in the medicine cabinet for a rainy day, and just reminding folks to keep them in a safe place, ideally locked, and that you can always dispose of them. And there are a number of take-back programs. If you go to the New York City Department of Health website, they can show you where a lot of the take-back ones are, but a lot of pharmacies also will take back opiates. Not all of them, but you can certainly go to your local CVS or Duane Reade or whatever, and they'll tell you if they don't take them back, which local pharmacy will. And so in preventing it, we're talking about stigma, we're certainly securing any opiates that we have, and then definitely addressing mental health issues and trauma. And then once someone gets into trouble with opioid use disorder, I think one thing I didn't quite clarify at the beginning of the treatment is that in the world of addiction, we think of all substances on one hand and opioid use disorder on the other hand. And one of the reasons that is in terms of how opioid use disorder presents, which is with the real risk of overdose death, and certainly the roles that doctors played in overprescribing opiates. Because if you relapse on alcohol or marijuana, you don't die the way you die when you relapse on opiates. And so that risk of death really puts opiate misuse in a category that's different from other substances. That being said, with fentanyl contaminating all other substances, it's sort of bled into, when people occasionally misuse cocaine or Adderall at exam time, those folks are now at risk for opiate overdose too, which makes this the sort of scary third wave of the opiate epidemic. So opiates are different in terms of how they present because they carry the risk of accidental overdose. And then the treatment of opioid use disorder is different. That is, the first line treatment for most other substances of abuse, certainly addressing the co-occurring mental health issues. There are good meds now for alcohol use disorder and nicotine use disorder. But the first line treatment often is sort of the psychotherapies, the psychosocial interventions, 12-step work like AA alternatives like smart recovery, motivational interviewing. The thing to remember about opioid use disorder is that these treatments are not sufficient to address it. That is, you can't get through an opioid use disorder by going to Narcotics Anonymous alone, even by going to a 30-day rehab or a 90-day rehab. And I think that's sometimes missed in communities. We think we can just send someone to the meetings and they'll get better. But we know that relapse rates on opioid use disorder approximate 100% if you're not on medications for opioid use disorder. And why that's such a problem, again, is that when you relapse, that's when you have the accidental overdose and die. And so we see a lot of people that pass away after they leave the 30-day rehab because they're not on medications for opioid use disorder. See people that are detoxed in the hospital settings and then aren't on medications for opioid use disorder, accidentally overdose. And then, the scary thing about the drug supply and never knowing if it has fentanyl or not puts you at risk as well. And so if you are struggling with opioid use disorder, the key is that you need to be on one of three medications: buprenorphine, methadone, or long-acting injectable naltrexone. And these are medications that have been as stigmatized as opioid use disorder. And people have a lot of, you'll see this in your communities or even among doctors, the buprenorphine and methadone are opioids, but they're much safer long-acting opioids that help a body and a brain heal from the opiates that people are using, illicitly, with have a lot of high ups and downs. And so people always worry about being on an opiate for opioid use disorder. But in fact, these medications are the most effective medications we have in medicine. They decrease the risk for overdose, accidental death, HIV, Hep C. They improve employment outcomes, family stability outcomes, pregnancy outcomes. They've been shown to be safe if you're pregnant, if you're an adolescent, if you're an older person. And so these really are the gold standards for people struggling with opiates. And so that's someone who's stuck on opiates for prescription pain medications. That's someone that's using heroin on the street. That's someone that's, got attached to a fentanyl contaminated product. For all these folks, we think that if they want to make their way to recovery, at least for a couple of years and sometimes much longer, they need to be on an opioid replacement treatment like buprenorphine, often called Suboxone, or methadone through a methadone program. There is one medication that we're increasingly using, and that's called long-acting injectable naltrexone. Instead of an opioid replacement treatment, it's an opioid blocker. It's a little expensive, not quite available completely yet, and so the gold standard really remains buprenorphine or methadone. And now you're going to see a lot of people after this talk, and you're going to say, I saw Dr. Avery's talk with Robin, and we really feel like you're struggling with opiates. You need to be on buprenorphine, methadone, Vivitrol. We need to get you into care. Let me connect you to these folks. Even if they say yes, even if they say no, the other big difference about opioid use disorder, or even for anyone struggling with any sort of substances, is that we feel we need to address them with a harm reduction mindset. And that involves giving things like naloxone rescue kits and fentanyl test strips to folks, so that they have these things to keep them alive. And I'm going to stop sharing my screen to sort of show you real quickly what those are, if you haven't seen them yet. And so, in the setting of the opioid epidemic, we're encouraging every community, anywhere you are, at your home and job, wherever you worship. Certainly hope all doctors' offices and everywhere else have it, to have these naloxone rescue kits. And these naloxone rescue kits, you can get them at your local pharmacy without a prescription. They're available in over 700 pharmacies. Rob and I do a lot of free trainings on Narcan, where we'll come to wherever you are, or on Zoom rather. And during COVID, we can Zoom with whoever you like, provide you the training, and then we can give you these kits. Or you can go to websites or apps like Stop OD NYC, to see where you can acquire these resources. But it's a wonderful resource, which is basically, if you see someone who has overdosed, you just take out your bag. It has a nasal spray in it. You tilt the head back, spray it in one nostril, and it helps someone come back from an opioid overdose. It basically, by squirting Narcan in the nose, it goes to the brain, knocks the opioid off, and allows someone to breathe again and to avoid an overdose state. And this is so critical in the setting of the opioid epidemic. The data is so strong behind Narcan as well. It's been shown that any community that gives them out decreases the overdose rate, decreases the number of people accessing treatment. And so, it's an important thing. Hopefully down the line, it'll be over the counter, but still you need to go to your local pharmacy or to one of my trainings or to the Department of Health trainings to be able to access them. Coming soon, we have it here at Cornell and York-Presbyterian. But soon the Department of Health will be rolling out their own program, and you'll see a lot more of it now that there's federal funding from Biden for it. But we will have fentanyl test strips available for folks. And so for folks that are still using substances, the fentanyl test strips are a wonderful resource in that you can take a little bit of the substance that you're using, put it in water, and then dip this little testing strip in that, and it will let you know if fentanyl, this powerful opiate that can result in an overdose, is present in the substances that you're using. And that gives people the opportunity to know, hey, I have a contaminated product, I don't want to accidentally overdose. But it also allows people to have Narcan handy if they still want to use. It encourages people to not use alone, and just to be more informed consumers of substances, so that we don't have accidental overdoses and deaths. There's always worry with Narcan, harm reductions, needle exchanges, any of these things that they'll encourage substance use. But again, these keep people alive. And as Robin's husband often says at the Narcan trainings, where there's life, there's hope. And so the idea with these kits and with the fentanyl is to keep people alive. Someone just wrote in the chat, please suggest test strip sources. Unfortunately, they're not mainstream yet. So basically, I have some. Like if you want to set up a training with me and Robin, then we'll get you the kits. The Department of Health, they were sending emails last week. In the next month, they're going to roll it out with their Narcan program, and it'll be more accessible. Different harm reduction agencies have them now. But it's just out of like readily accessible territory, but it will soon be that way. We have our own program we're piloting here at the hospital, and I'm happy to get the kits to folks in the audience today. You can, I'll add my email to the chat if you want to set up trainings with me or get any of these kits. I'm happy to supply them. All right, in sum, our attitudes may be worse towards those who are struggling with substance use than towards any other medical or psychiatric condition. And so we have to be aware of our attitudes because, folks that are struggling with substance use are encountering negative attitudes wherever they go, at school, at home, through the legal system. And so we need to be the people on the front line, whoever we are, offering them compassion, kindness, and support. And then when we see people struggling with opioids, we have to recognize that it is something different than other substances and that it carries a real risk of accidental overdose and death. And because of that, we need to hopefully prevent it by addressing co-occurring mental health issues, approaching with harm reduction strategies. But then when people do get into trouble, to connect them to the medical care that they really need. And that often involves being on medications like buprenorphine, methadone, or Vivitrol. And that's all I have. We have about 15 minutes, though, to discuss any of this. Robin and I are both open for questions. You can feel free to ask us anything. And I appreciate you all coming and listening.
Thank you so much, Dr. Avery. It was wonderful. And thank you so much, Robin Keldner, for coming and just being here today. That was very brave of you. And I know we all enjoyed that story. It was very brave and very touching, very touching.
Thank you. Thank you very much. Can I just add one thing?
Please.
Sorry, allergies, sorry. I think, if I could say one thing that was the most important thing for me to get across is that this can happen to anyone. And then I think we need to be able to accept that this could be your story. And I hate that. I hate that this could be anybody else's story. I hate that it's my story, that it's Zoe's story. But that, I think if we could accept that this does happen to us, not someone else, but it's us, then maybe we could get ahead of all of it. We could get ahead of the stigma. We could get ahead of the treatment. We'd be more accepting of all of it because we wouldn't be blaming. So I feel like if I could wrap up like one thing that I'd want to leave with, it would be that this could be you. And I wish it wouldn't be. And that's the only reason why I share a story like this, because I just don't want this to happen to other people.
Mm-hmm.
Robin Larry Brindle here. It always strikes me as ironic. Your message is so clear and so genuine, and people say some variation of I really liked or appreciated, enjoyed. Your message is so painful and so trenchant. Enjoy is the last word I would use, but grateful and informed, I think is more to the point. One comment, bit of advice. You didn't ask for it. I'll try it anyway. I'm wash and wear, drip dry. Your tears will not make me shrink. Don't ever apologize for your tears. They're real. They're genuine. You paid your dues. You're entitled. And what you did was a great service to the room, and I want to thank you for it.
Thank you very much. Thank you so much. And thank you for caring about this health issue. We need everybody to care as much as all of you do.
This is Lula May, and I want to thank you both. And I was so moved, and I've heard this discussion a lot, and I've even given talks on opioids, but I really, truly enjoyed this one And I'm going to be getting in touch with Dr. Avery. Agnes will be reaching out to him because I want the churches to hear this from this point of view, because we talk about naloxone, we talk about, how to administer naloxone, but we don't talk about the stigma. We don't talk about the attitude of the person who is actually giving the naloxone. That has a lot to do with care. So I will be reaching out to both of you, and I just want you to know I enjoyed thoroughly and appreciated the transparency with the talk. Thank you both so much.
Thank you.
Hey, this is Jeff. So I did have one question I thought Dr. Avery, if you could sort of address with everybody, and that is
Sure.
that if people know somebody who is suffering from an opioid addiction, but is unwilling to seek any help for it, do you have any advice on how to speak to these individuals and convince them that they need to seek help or they need to do something about it?
Yeah, that's a real tough question, and certainly different for everyone. And I think one principle that we always keep in mind when addressing someone who's ambivalent about change is that there's always a part of them that wants to change and a part of them that doesn't, but they're doing the best they can. And so it's a, as much as it can feel like a struggle between you and them, or them and something else, it's in some ways a struggle between them and them, trying to sort of make sense of how to deal with the pain and with everything that's been going on in their life. And so the key is really just to not do some of the things that have been done historically, which is like let people hit rock bottom and distance yourself, or punish them, or try to finger wag, like, don't you know what you're doing, you're going to kill your liver, your kidney, or that sort of thing. But rather, with kindness, with love, hang in there with them, let them know that you're there to help them get connected to either mental health care, which is probably helping them understand the why behind why they use, but also being there to help them get to substance use care. And so, I think just hanging in close with love is sort of the best we can do as a family member, and being prepared ourselves. So having Narcan available, knowing what the resources are by attending things like this. And it's a hard disease, though. I mean, it's hard to change, and even when we do everything perfect, it can take on a life of its own, just because it's a disease, and it has that scary risk of overdose. But I guess that's some of the things I would say. Robin, do you have other advice for families or friends?
Well, I think, what you're saying is that, and I agree, it's not everybody gets well after they've had chemotherapy and radiation and treatments, all the treatments recommended if you have cancer. I mean, everybody responds to things differently, and we don't scold people when they don't get well when they have cancer, but we do scold people when they don't get well and they don't respond and they have trouble complying with this particular health issue. And I think if we could just understand that it's not that they're not doing what it's not purposeful non-compliance, it's a health issue. And you can have an infection that responds to an antibiotic, and you can have an infection that does not. Once we start to do that, once we start to realize with compassion and humanity that people are doing the best they can. I mean, when Zoe had to tell me that if she could do better, she would, I thought to myself, I'm never going to do that again. I have friends that I see doing the wrong thing when they have a particular health issue. And I remind myself to this day, if they could do better, they would. If they could do better, they would. And I think we need to hold on to that.
Yeah, thank you both very much.
There are other resources I'd recommend. I mean, there's a good book, Beyond Addiction. There's craft treatment, which is therapy that helps family members, that's available in different settings. There's Al-Anon, like the 12-step alternative to AA, that can provide supports to families. And so I would also say to those that are struggling with a family member, also get their own support as well, either from a mental health provider or from these different support groups.
And
Dr. Avery, please go
add
first,
one
Robin.
thing? I'm sorry, can I just say one thing? Which
Please go
is
first.
that I never understood harm reduction. And I think we have to accept that harm reduction saves lives, and not everybody is ready to get completely well just because we want them to. And maybe accepting that, you know, people will get well as they can and as they want, but we can keep them much, much safer. Right, Dr. Avery?
Exactly.
Okay.
Larry?
Yeah, hi. Couple of things. Al-Anon specifically is for the families. And even though they phrase it as, and their histories from specifically alcohol and the families of alcoholics, if there's no alcoholism in your family, but there's mishigas and craziness, you are still subject to the family problems and the emotional consequences. So whether the family is workaholic, drug addicted, boozeaholic, Al-Anon is a more general, more global tool. The other thing, and I want to say something, I'm probably wrong. I'm probably dead wrong. But if I say it, you'll have a chance to clarify why I'm wrong. In your presentation, you made a distinction between opioid addiction per se and all the other addictions. Obviously, the mortality and the morbidity are sudden, they are intense, and they are avoidable. I'm no disputing it. I would want to ask about the commonalities. You're looking at specific medical mitigation, which understands the chemical pathways. That part I get, but separate from the chemical intertwining with the nervous system. I'll be curious to hear if you'd like to speak about the commonality.
Right. No, those are two good points. I mean, one thing that combining Robin's last thought with your comments on Al-Anon first is that Robin and I often have done a couple, I think now, Narcan trainings to Al-Anon groups and sort of combining the harm reduction with the family support. And we work with a lot of families sort of combining one modality with the other, because I think you need all of the above. And then, yes, I think the difference is the mortality, but there are a lot of similarities between all the different sort of addictions. And so one of the big similarities is that they hit the same reward pathways and they hijack the same neurocircuitry in the brain, slightly different with whatever, you know, substance or behavior that you're engaging in. But they do trigger the same reward pathways, and they often respond to similar sort of anti-craving medications. And so there's that commonality of hijacking the reward pathway. There's often also the commonality of, a lot of overlap between trauma and mental health issues as sort of things that result in substance use disorders. And the trauma epidemic is tied to the substance use epidemic. And so, I'd say those are two of the big common things: the reward pathway being hijacked, and then sort of the risk factors for developing them.
Do you work yourself in the alcohol addiction space, or do you work closely with colleagues, or they parallel tracks independently?
No, I mean, alcohol is still a big thing that we tackle as addiction professionals. I mean, at York-Presbyterian, for example, we had 9,000 presentations for the medical consequences of alcohol in the last year versus 1,000 presentations for opioid use disorder. And so, there's 9 times the people admitted for consequences of alcohol. I think one of the striking figures in COVID-19 that's often cited is the number of people drinking was insane during COVID-19. I mean, just incredible amounts of people. I've never seen more young women present to the hospital with severe medical consequences of drinking, mothers, everyone else, because of basically losing outlets for how to cope during COVID-19. You can't exercise, you can't go outside, you can't socialize. Alcohol became an easy, accessible, sometimes socially sanctioned way to cope during this last year. And so, most addiction works with alcohol, frankly.
Pass it on another one. This one I don't think is generally commonly known. In bariatric surgery, there are quite a number of different methodologies. Early on, there was something called Roux-en-Y as one of the procedures. And it's now known that I think about 5% of all Roux-en-Y patients become alcoholic because of the surgery. And the patients don't know it, and they suddenly become alcoholic. Having been a glass of wine with dinner kind of person, they suddenly find themselves in an alcoholic mode. This is tricky stuff.
It is. No, we see that, and the absorption changes, the impact on the body changes, and so that's a good point. And as Robin was mentioning with the eating disorder history in Zoe, is that we often don't highlight to folks the risks as they come up medically for developing substance use. When someone has a mental health struggle, when someone has different physical issues, when someone has trauma, we should be highlighting that you may have an exaggerated response to substances if exposed to them. And it's something that you need to be mindful of in your future health timeline. And so that's sort of the prevention aspect. They should be telling everyone who gets gastric bypass or similar procedures that your absorption is going to change. You may have an exaggerated response to drinking going forward.
Well, physiologically, what's happening is most doctors are lousy physiologists, and most surgeons are terrible physiologists. And as far as they're concerned, once the stitches are gone, their job is done. But the idea that things like Roux-en-Y will damage vitamin D absorption, which generates calcium absorption, which gives you osteoporosis and dental problems. The typical bariatric surgeon isn't thinking about dental problems. Medicine is the easiest profession in the world to follow badly. Doing it well is really, really hard.
Right. I agree.
Just want to interject quickly. I want to open up the polls for today. If everybody could just quickly take 2 minutes to fill it out while we continue our questions for today's talk.
Are you putting a link in the chat, Agnes?
It should be open now.
Thank you.
And yes, please let us know if anybody else in the audience has any questions. I guess everybody's filling out the poll.
The quick poll, don't worry.
And then Dr. Avery, I see that you left your email in the chat for everybody. Are you okay with us directing people who want the trainings, some more questions to you? Okay, perfect.
Of course, no, we're happy to do it.
Thank you very much. All right, Agnes, anything else?
Yeah, I was just going to say that this session was recorded today and will be posted on YouTube. So I will send everybody the link, and then they could just spread it out to friends and family. I will include Dr. Avery's contact information as well.
Thank you, everyone.
Thank you.
Thank you, everybody.
Thank you. Thank you both.
Thank you, Robin. Takes a lot of courage to do what you did. It's much appreciated.
Thank you
And
very
of great
much.
value.
Thank you so much. Really appreciate hearing that. Thank you.
I'm a dad, I'm a parent, I get it. I really do.
If there's anyone in the audience who'd like for this program for their churches, just please let Agnes know.
Oh yes, Reverend Phillips.
Yes.
This is Miss Herbert. I would love to have this program for my church.
Oh, okay. Let me know when, and then we'll find out if Dr. Avery and Robin are available.
Okay. And Dr. Jeff, it was nice to see you. He's in the background there. I'm setting up.
Yes.
And Dr. Avery, this program was, I really read it. This presentation was wonderful and very just simple. Anybody could understand. It was made very simple to be understood. And I thank you very much for presenting.
Of course, no, thanks for coming. It's our pleasure, and we're happy to be wherever. We just did Rob and I just did this last week. Well, doing it in 2 days, we're happy to bring this to wherever we're needed. So including with the Narcan and fentanyl test strips.
Thank you.
Thank you, everyone. I'm gonna say goodbye. Thank you so much.
Thank you. Thank you. Thank you,
Robin.
everyone.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye.
Good night.
Bye-bye.